It's a very good question. The data seem to show that the patients who are PD-L1 expressing, particularly if you're looking at a score that's generated from the tumor cells and the tumor-associated immune cells, have much greater likelihood of deriving benefit from the PD-1 directed drugs. That is not to say that there are not a small number of patients who don't have that, who benefit. And so I don't think that for the multiply treated patient who's platinum refractory, that you would not give a PD-1 directed medication to someone who is PD-L1 negative. For the patient who's a little bit more symptomatic, who still has chemo options, perhaps for the person who's relapsed just sort of at the end of that 6-month post-chemo radiation window, if their PD-L1 is truly absent, there's no staining on tumor cells or immune cells, my own view would be that I'd probably give them another whirl at chemotherapy before I went to one of these agents off trial. Now, if you had a study where you could be offering them combination immunotherapy, I think that would be different. And then it may also help you to understand what to do if you have a patient who appears to be progressing. It's a little hard to sort out if it's pseudo-progression or real progression. Obviously, if they're PD-L1 negative and their odds of responding were pretty low in the beginning, you might be a little bit quicker to cut bait, I think.